So this is the first case of septic arthritis. Before starting, you need to know what are the risk factors of septic arthritis. You've got two common risk factors of septic arthritis: infective endocarditis or sickle cell anemia or sickle cell disease. Usually infective endocarditis will cause septic arthritis by this common organism, Staph aureus. Okay. However, in sickle cell anemia, septic arthritis is usually caused by salmonella. Why? Because sickle cell anemia leads to autosplenectomy, and autosplenectomy increased the susceptibility of capsulated organism infection as salmonella. So salmonella is the causative organism of septic arthritis in sickle cell anemia patient. However, Staph aureus is the causative organism of septic arthritis in infective endocarditis patient. Okay. Okay, septic arthritis, involvement of the joint. Okay, usually septic arthritis is monoarticular. This is very important. Once you see that only one joint is affected, this is septic arthritis. Septic arthritis should be considered with monoarticular involvement of the joint. Okay. Okay. How septic arthritis involves the joint? Early involvement and late involvement. Early, there is joint effusion. This is very important in the diagnosis of septic arthritis. However, late, there is joint destruction. Okay, let's start with joint effusion. Okay, the presence of intra-articular infected fluid. Okay, joint effusion. In septic arthritis, okay, it's not a clear effusion. It's infected fluid and intra-articular. Okay, so this effusion will cause widening of the joint space, cortical erosions, and the periarticular osteopenia. So this infective fluid will cause widening of the joint space. This is a very important sign in the early disease. Widening of the joint space will lead to displacement of the fat planes. Okay, will lead to displacement of the fat planes in the joint. This is a common sign, a common radiological sign that indicates joint effusion. Okay, the displacement of the fat planes, of the periarticular fat planes. Okay, the second sign, cortical erosion. Okay, cortical erosion is seen as cortical irregularities on X-ray or non-visualization of the cortex. Okay. Okay. Next sign, periarticular osteopenia. Okay, periarticular osteopenia. Okay, this is bone marrow edema. Okay, last sign is adjacent muscle edema and swelling and maybe abscess formation. Okay, adjacent muscle edema and swelling. Okay, so let's compare the early disease of septic arthritis with the late disease. Okay, late disease of septic arthritis involves joint destruction. Okay, this is not early. The fluid, the infected fluid inside the joint will lead later on into joint destruction. Okay, so how can I see the joint destruction? By narrowing or loss, by narrowing or loss of the joint space. Okay. Okay. Also, you can see joint dislocation or subluxation, okay, due to joint destruction. Okay, so joint destruction, first sign is narrowing, loss of the joint space, or maybe associated with joint subluxation and dislocation. Okay, the second sign is subchondral erosion. Okay, so this is subchondral erosion. It's not cortical erosion. It's not periarticular osteopenia, periarticular edema, okay, bone marrow edema. Now the erosion extends from the cortex into the subchondral, okay? Subchondral erosion means bone destruction. Now we have bone destruction. Here, cortical, only the cortex is destructed. Cortical erosion, okay? Okay, and because of the bony destruction, due to bony destruction here, this will lead to intra-articular bony fragment. So this is a severe form, okay? Only the destruction here is in the cortex. However, the destruction here involves the subcortex, okay? Subchondral erosion and intra-articular bony fragment could be noted, okay? Okay. The adjacent muscle will not show edema and swelling. No, the adjacent muscle here can show gangrene. Okay, the adjacent muscle here may show gangrene. How to see gangrene of the adjacent muscle? You will see a collection of gas in the muscle. Okay, how can I see the adjacent muscle gangrene? By I will see collection gas collection in the muscle. Okay, this will be seen. This gas collection will be seen on X-ray. Okay, so let's start with the first case, which is an example. Our first case of septic arthritis, which will be illustrated here in this video. Okay, is an example of a late case of septic arthritis. So we will go through the signs of late septic arthritis. Okay. Okay, so this is an elderly lady with history of infective endocarditis. Okay, so what are the findings? What are the findings? Okay, the first finding is there is inferior subluxation of the right humeral head. Okay, so here the first finding, due to joint destruction and loss of the joint space, there is joint subluxation. Let's see the joint subluxation here. There is inferior subluxation of the right humeral head. Inferior subluxation of the right humeral head. Okay. An ill-defined region of lucency is seen in the inferior medial aspect of the humeral head. Okay, can you see this? Ill-defined area of lucency in the medial and the inferior aspect of the humeral head? Yes, this is an example of subchondral erosions or body destruction. Okay. Okay, There is an ill-defined area of lucency in the inferior medial aspect of the humeral head. Third finding, there is an apparent bony fragment within the joint due to bone destruction. Okay, can you see this? Can you see it? This is a bony fragment seen intra-articular. Okay, intra-articular bony fragment could be detected due to bone destruction together with the subchondral erosion. That means that there is a severe form of septic arthritis here. This is a late form of septic arthritis disease. Okay, so what about the adjacent muscle? No, I can't see any gas collection here in the adjacent muscle. No gas collection. So you know that the soft tissue only can be detected on the MRI. However, if there is a gas collection, which is a sign of gangrene of the muscle, yes, this sign could be detected here on the chest X-ray. Okay. Okay, I will try to find. Let's try to find. Yes, this is the sign. Can you see the collection here in the adjacent muscle? Yeah, this is a sign of gangrene of the muscle, which means a severe or late form of septic arthritis. Okay, so what is the interpretation here in this case? The findings will be suggestive of unilateral inflammatory process in the right glenohumeral joint. Unilateral inflammatory process in the right glenohumeral joint. Okay. Along with the history of infective endocarditis in this patient, along with the history of infective endocarditis, the most likely diagnosis is septic arthritis. Septic arthritis should be considered. Okay, however, inflammatory arthritis, you know that septic arthritis is infective arthritis. So when you see infective endocarditis in the history, this is infective arthritis. This is infective arthritis. Whenever you see this is infective endocarditis, yeah, this is infective arthritis. This is infective arthritis, okay? However, inflammatory arthritis should be considered as a differential diagnosis, okay? You know that most of the inflammatory arthritis should be bilateral. However, reactive arthritis is the only unilateral form, okay? So we have here unilateral inflammatory process. So you need to mention reactive arthritis in the differential diagnosis. Management. The first management here, you need to say, I would correlate these findings with the patient's history. I would correlate these radiological findings with the patient's history of either fever. Did he say fever here? No. Okay, so if the patient has fever, yeah, the most likely diagnosis is infective endocarditis. Okay. If you see infective endocarditis in the patient's history, yeah. Sickle cell disease in the patient's history, yeah. This is infective endocarditis. Okay, and I told you why. Because sickle cell anemia causes autosplenectomy So the patient now is susceptible for capsulated organisms infection like salmonella. So salmonella may be the leading cause of infective endocarditis. So you need to correlate the radiological finding with the patient history of these three: fever, infective endocarditis, sickle cell anemia. Okay. Second one is I would like to look at previous imaging to look for a previous joint space widening, because this is a late case. This is a late case. Okay. The patient is commonly or most likely in his previous imaging will show the early case, the early form of the disease with widening of the joint space. So this late case, if you look through its previous imaging, you will most likely see widening of the joint space before the narrowing and the joint subluxation and the joint dislocation you see right now. So this is very important. I would like to look at previous imaging, to look at previous joint space widening before the current narrowing and subluxation, or to look for a rapid loss of bone density. This rapid loss of bone density. Of course, this patient, if you look at its previous imaging, you will see the periarticular osteopenia in the previous imaging, okay, rather than the erosions and bony fragments you see right now. So you will see previously the periarticular osteopenia. Okay, so I would like to look at previous imaging to look for a rapid loss of bone density, as a rapid loss of bone density is a characteristic finding in septic arthritis. This is a characteristic finding in septic arthritis. Third one, I would recommend image guided aspiration. Okay, so now we are trying to diagnose. I would recommend image guided aspiration of the shoulder joint fluid. This is the mainstay of management. Okay, this is the golden standard of diagnosis. Image guided aspiration. This is very important for your clinical background. Image guided aspiration is the first management you would recommend for any septic arthritis case. Image guided aspiration of the shoulder joint fluid. Okay, this is the golden standard management. Okay, why? Because the aspiration of the shoulder joint fluid will allow culture and sensitivity for culture guided antibiotic therapy. So image guided aspiration of the shoulder joint fluid is very important. Fourth thing, or I would recommend an orthopedic referral to guide treatment, which may include intravenous and oral antibiotics as definitive treatment. Intravenous and oral antibiotics as definitive treatment, as well as symptomatic treatment. So we have two types of treatment here: symptomatic treatment by image guided drain placement, or surgical drainage of the abscess. Okay, so if this patient is proved to have abscess, okay, in his muscle, he needs symptomatic treatment. He needs the abscess to be drained either by image guided drain placement or surgical drainage of the abscess. Okay. Um, okay. I just forget one thing here, that I may recommend. Okay, I would like to look at previous imaging. Okay, and I would recommend an MRI of the shoulder. I would also recommend an MRI of the shoulder. Okay, to detect the degree of joint destruction and the involvement of the soft tissue. Okay, so to assess the degree of joint destruction and the involvement of the surrounding soft tissue. Okay, so this was the first case of septic arthritis. Okay, next video will be the second case until we finish all types of septic arthritis that you will face in the FRCR exam. Okay, that's all. Thank you.